Let me take a couple of questions here, and this is one I sort of hesitated for a moment, but it's probably on people's minds, and I'm going to give that to you because you were talking about using scopes and putting down the throat. Is this related at all to the kind of surgery Joan Rivers had?
Good question.
So you started with the scopes, that's why you got that one.
No, not really. I mean,
it's using some of the same tools, but this is not, this is still very different now.
Yes. I don't know exactly what went on with that particular case, so it's difficult for me to comment on that. But it's important that people know that when we carry out these endoscopic procedures, it's in a controlled environment. The patients are, this is not done under local anesthetic. The patients are all anesthetized, they're asleep. The whole situation is controlled, so there's no danger to the patients during this period. And the surgeons then is able to, in a controlled fashion, remove whatever cancer is there. And then afterwards, the patient is then awoken again in a hospital environment, in a controlled environment, and go through to the recovery room where they are then monitored, and after 2 or 3 hours of monitoring are then either discharged or go to the ward. So, and that's a different situation to the Joan Rivers situation, which was in a private practice endoscopy suite. It really wasn't a controlled environment like a hospital environment, and therefore you can't really compare these two different situations.
I'm sorry.
And also, if I may add, I mean, this is where proper patient selection comes in. So you don't really want to bring anyone to the operating room unless that's the right thing to do for that person. Okay. And it's a very stringent selection process.
Enough on that already. But I'm going to give you another time. This is something that's always been out there in one form or another, and that's whether or not head and neck cancers may be caused by some type of electromagnetic radiation, whether it's our cell phones, cordless phones, that sort of thing. We've heard that a lot. Is there any evidence to say yes or no when it comes to that?
Not to my knowledge. Not to my knowledge. I mean, you know, there's cancers inherently are multifactorial, that there's many things that potentially can cause cancer. And if you were able to do an experiment where, you know, you have 1,000 people who use cell phones and 1,000 that don't, and you isolate them from every other influence possible, yes, you may someday get the answer. But in my judgment, there is no data that convinces me to say that, okay, do not use cell phones. I wish I could desperately say do not use cell phones. That would make our lives a lot easier, but I don't think
people wouldn't listen anyway at this,
at
this point.
Yeah.
Interestingly, here's a question that came in from Twitter in Australia. So we have people listening in all over the world. What about, Dr. Shah, HPV vaccinations? They're asking specifically for teenage boys, but it could be for teenage boys and girls.
I think, you know, that's the direction we should be taking. The current recommendation in the United States is vaccination of girls at the age of 9 and boys at age 11. Sexual promiscuity in the United States, maybe.
No, I think the idea is to do it before they become sexually active.
So that's the age recommendation.
Right. It's not that the 9 or 10-year-olds are
and I
having
think,
sex.
you know, it would be wonderful because the vaccines currently available are only for 2 or 3 types of HPV viruses, HPV 16, HPV 18, and probably HPV 8. But there are dozens of HPV viruses for which we don't have the vaccines.
These are all different strains of the
Correct.
HPV vaccine.
Correct.
Or HPV
so
virus.
while we may control HPV 16 and HPV 18 associated cancers by vaccinating children with those two vaccines, but we don't know the other strains of the HPV viruses will be causative in genesis of cancer 5, 10, 20 years down the road.
But for now, what we have is
I
okay.
think it is. It's a wonderful thought. It should be implemented, and at least it will address the problem to a certain extent for HPV 16 and 18 viruses, yes.
So Dr. Ganley, here's another one for you that I hope isn't as bad as the last one. But it's also one that is often talked about, is dental x-rays, perhaps as a causative factor for certain types of head and neck cancers. Any evidence for that?
It's interesting you should say that. Many patients actually ask me that when I see them, particularly patients who have cancers of the tongue or the floor of the mouth, but also patients who come with thyroid cancers. It's a very common question for patients with thyroid cancer, is my dentist never used protection on my neck during the x-ray. Is that a cause for my thyroid cancer? That's an impossible question to answer. So to my knowledge, there is no evidence that the use of dental x-rays is associated with cancer in the mouth or cancer of the thyroid. But of course, I can't completely exclude it, because it's, I guess in theory, there's a theoretical risk, but I think it's a question which is probably impossible to prove or disprove.
Certainly in any one case, one individual.
Yes.
And I guess it's probably important to point out that today's dental x-rays are not
exactly
your grandfather's dental x-rays.
Yeah, these are tiny doses of radiation, localized areas of radiation now that you get. When you go to the dentist now, you just get an x-ray confined to 1 or 2 particular teeth as opposed to the whole jaw.
And the digital x-ray and the digital, what used to be film, now the digital sensor is also, as I understand it, tremendously reduces the dose needed to create an image.
So the doses are tiny. So I really don't think the doses that you get from a single x-ray is sufficient to produce cancer.
I tell the story of people that I see doing this, going, that's terrible, that dental x-ray gave me cancer, but that's another story. But back to thyroid, radiation in the past did lead to some thyroid cancers.
Radiation exposure is a known etiologic agent, causative factor for genesis of thyroid cancer. And the data for that comes from the atom bomb exposure in Japan during the Second World War. There was a huge rise in thyroid cancer in people who survived the Hiroshima and Nagasaki atomic bombs. But the more recent observation comes from Chernobyl. 1986, the Chernobyl accident happened with the fallout exposing tens of thousands of children in Belarus and Ukraine, where the incidence of thyroid cancer in children skyrocketed and started falling off about 1998 onwards. But 86 to 98, there was a huge rise in the development of thyroid cancer in children. Adults who were exposed to that fallout had a longer incubation period, and they did not manifest rise in thyroid cancer early on, but that started becoming evident after 2000, after 14 years. And that is still an ongoing number. There is an ongoing registry of Chernobyl exposed population and thyroid cancer. But we do know that radiation exposure does cause thyroid cancer. Children treated, for example, for Hodgkin's disease with radiation during your childhood, where neck was radiated, have a higher incidence of thyroid cancer in adult age. So there is a known causative factor, but not dental x-rays. X-ray treatment given for acne, it used to be the standard of care for treatment of acne in the 1950s and 60s. Those children, when they became adults, have a high incidence of thyroid cancer. So I think radiation exposure does have an important role in keeping surveillance for identification of thyroid cancer. Fortunately, this thyroid cancer is not more aggressive than the garden variety other thyroid cancers, but the risk is high, yes, indeed.
Dr. Patel, let's talk about salivary gland cancer is not very common or somewhat common.
Relatively not.
Relatively not common. But also as a consequence of treatment, particularly radiation for other head and neck cancers, you may end up irradiating the salivary gland as well. Either removing or irradiating the salivary gland so that it's damaged has some significant sort of side effects for a patient in their mouth. Tell me about that, because
Yes,
people think of saliva as just sort of something that kind of helps lubricate your mouth a little bit, but it actually has a serves very important function.
Absolutely. So the impact of treatment on saliva is not as profound with surgery alone as it is with radiation. Largely because surgery, removal of just one big salivary gland doesn't really impact on saliva production as much as radiating or exposing a larger field to radiation does. Now, thankfully, radiation techniques have evolved over the years, so we are very reliably able to spare radiation to certain parts of the face or the head and not expose the salivary glands to radiation. So the incidence of xerostomia, or dry mouth as it's called, is much less with modern day radiation. The impact of less saliva or altered saliva, so it's not just the amount of saliva that you produce, but the nature of saliva that's produced. Because it's thicker, it doesn't have the same consistency as normal saliva. It influences the flora, the bacteria, and the lining of the mouth. So things like dental caries. You have to be very careful looking after your teeth if you've had radiation. And the reason largely is because the saliva that you produce after radiation is not quite the same as you did before radiation. So you're at a very high risk of developing caries and all
cavities.
Cavities.
Dental cavities. Mm-hmm. And that brings up one question here. Can you transplant salivary glands?
There's a whole industry in some parts of the world where people are very excited about doing those kind of things. It has limited value in my judgment because, like I just mentioned a minute before, radiation techniques have improved so much that now I don't think there is any real role for that kind of an operation.
It sounds like a pretty big deal to deal with, to simply
right.
deal with.
And plus, in many instances, it's not really the best thing to do for the patient.
There are a couple of questions, Dr. Ganley, finally here about having biopsies for, I guess, suspicious masses, and the biopsies are, quote, inconclusive. Now what do you do? Ignore it, follow it, have another biopsy? What happens?
I think one of the important things for the patient is they have to go and see a specialist in cancer who has a particular interest in the area of the body that biopsy has been done, and then rely on the experience of that cancer surgeon, because they will then know from their experience whether or not that lesion is suspicious or not. And that will then determine whether or not any further investigation or treatment are required. And that would entail either carrying out X-rays, CT scans, or PET scans, or MRI scans, or the need for another or second biopsy. Another important thing is to have a good pathologist who's specialised in a particular area of the body to review these slides. So that's something that Memorial is really, we're really proud of, the fact that we've got really wonderful pathologists who are specialized in different parts of the body and really have a huge experience in diagnosing cancer and especially in diagnosing very rare types of cancer.
That really is actually also very important, because I think many people think that once you do a biopsy and you look at a slide of what may or may not be a tumor, that if it's cancer, it's got little neon lights that say cancer or I'm malignant on it. And it can sometimes be a very subtle and judgment call, and that's where, again, the experience of the pathologists here at Sloan Kettering is so much more important in making that kind of diagnosis. Finally, let's go back and sort of talk a little bit about, just to re-emphasize the value of this whole team approach. You're all surgeons, but you're pointing out that there's a lot of other people that are part of this team that are really important in coming up with both control of the cancer and the quality of life outcomes, Dr. Shah.
You know, it's about now almost 18 years that Memorial Sloan Kettering Cancer Center developed disease management teams. And
disease management teams?
Yes.
For each of the different...
For a variety of different diseases: breast cancer, lung cancer, prostate cancer, head and neck cancers, which is essentially a group of physicians interested and involved in taking care of just that cancer. They spend their whole life treating that particular disease, whether you are a surgeon, a radiation oncologist, medical oncologist, an endocrinologist, a rehabilitation specialist, a radiologist, and a pathologist. All are component members of a particular disease management team. Because it is not only just treatment, it's even in diagnosis. Interpretation of a CAT scan by a head and neck radiologist is going to be much superior than a radiologist who reads a head and neck CAT scan, a sonogram of the breast, an MRI of the abdomen, and X-rays of the legs. The expertise is going to be very different. So we need an expert radiologist, an expert pathologist to have the strength in accurate diagnosis. And then we need the minds of all the other specialists I mentioned: surgeon, radiation oncologist, medical oncologist, endocrinologist, rehab specialists, and other allied specialists, to give their opinion, advice, and their input in developing a treatment algorithm for each particular disease entity. And then the entire team essentially follows the same algorithm. So we are surgeons, but if a patient who comes to us with a problem which is best treated by radiation therapy, that is the advice the patient will get, even though he has come to see a surgeon, and vice versa. If a early stage tongue cancer happens to see one of our radiation oncologists, they will be told that no, you need to go and see the surgeon. Here is Dr. A, B, or C. Pick your choice, but go to see one of the surgeons, because your cancer is best treated by an operation. So, and that is the strength of a multidisciplinary team, that the treatment algorithms are devised by these minds put together.
Well, I'm going to let the word of the chief, the real chief, be our last word. I hope that we have conveyed some valuable information to you this evening. There is more information at mskcc.org, and in a few weeks this panel will also be posted on the website, MSKCC Memorial Sloan Kettering Cancer Center. That's how you can remember .org, and there you can go there for more information. I want to thank our panelists this evening for helping us out and helping hopefully inform you about head and neck cancer this evening. Also, I believe in your packets you have an evaluation form in there. Please fill those out for us. This is how we can improve on our Cancer Smart panels. You can be honest, but be kind. and pass that along as you leave here. And again, thank you for being here, and get home safely. Good night.